Good evening, everybody. I'm Dr. Marla Shapiro, and I will be the moderator for this evening. It gives me great pleasure to have two world-class speakers join us tonight. With you as an international audience, we've got Dr. Steve Goldstein, who will be talking about the role of ultrasound, assessing menopausal bleeding, and Dr. Denise Black, who will be talking about the management options for unscheduled menopausal bleeding. So gives me great pleasure to welcome both of them here tonight. This program that we're seeing tonight was supported by an unrestricted educational grant from Bezins Healthcare, and they had no role in the selection of the topic, the selection of the speakers. They have not vetted or reviewed the content of the speakers' presentations, but we thank them for their support. Now, for this evening, we'll first have Dr. Goldstein speak, followed by Dr. Denise Black. Dr. Steve Goldstein is a professor of obstetrics and gynecology and director of gynecological ultrasound at New York University School of Medicine. And currently, he is the president of the International Menopause Society. I think he's a past chair, past president, past member of every other committee that you could possibly think of in the world. But he really has done pioneering work in menopause and perimenopausal ultrasound that's led him to become an internationally acclaimed, world-renowned expert. So we're very grateful to him to be talking about this topic, and I can't think of anybody more qualified than Dr. Goldstein to be speaking to us tonight. After he's finished speaking, I will introduce Dr. Denise Black, a fellow Canadian. That gives me great pleasure to introduce her as well. And I want to remind you that your questions can be put in the Q&A box. We will be taking questions and answers after both presentations. So without any further delay, I would like to hand the screen over to Dr. Goldstein to start his presentation.
Thank you very much, Marla, for that kind introduction. The topic that I'll be addressing today, as you heard, is the role of ultrasound in assessing postmenopausal bleeding. My disclosures include some equipment loan from GE Ultrasound for research, and I am a consultant to both Cook Medical OBGYN and Cooper Surgical, for which I do receive consulting fees. So in the early 1990s, transvaginal ultrasound was utilized in women with postmenopausal bleeding to see if it could predict which patients lacked significant tissue and therefore could avoid a DNC or even an endometrial biopsy, its discomfort, expense, and risk. Consistently, these early studies, observational studies, found that a thin, distinct echo less than 4 or 5 millimeters was shown to effectively exclude significant tissue in postmenopausal women with bleeding. And here's an example. This, let's say, a 64-year-old woman who wakes up, hasn't bled in 13 years. She has stain in her underwear. She comes into my office. We put the vaginal probe in, and you see this thin white line. Please, we don't call it a stripe. It's an endometrial echo. And what this represents is the interface between two sides of inactive atrophic endometrium. Or another example of a patient who's awakened with some postmenopausal bleeding. You can see the cervix up here, and the endometrial echo takes off towards the uterine fundus, surrounded by a nice hypoechoic junctional zone. So these early observational studies, we actually had the first in 1990. The thinnest endometrium that had a case of cancer in our study was 7 millimeters. Varner had one at 5, and Granberg had one at 9. Just as an aside, the cancers tend to bleed early. The thickest endometria, in my experience, are inactive polyps and simple hyperplasia. Well, we needed to validate these early observational studies clearly, and most of the good work came out of Western Europe. This was known as the Nordic trial. Now remember, this is women with postmenopausal bleeding, 1,168 women. For an endometrial echo less than or equal to 4 millimeters, there were no cancers. Enrico Ferrazzi in Italy, 930 women, less than or equal to 4 millimeters, 2 cancers, less than or equal to 5 millimeters, 4 cancers. Barrett Gull, Elizabeth Epstein, Barrett Gull. And if you combine all of these studies together, for an endometrial echo less than or equal to 4 millimeters, the incidence of malignancy was 1 in 917. Well, would you even still want to do a biopsy in such a patient? We just pointed out the chances of having cancer with an echo less than or equal to 4 millimeters is significantly less than a biopsy. And I'm going to address that in detail later. But there is data, if you do a biopsy on a patient who's got an endometrial echo less than 5 millimeters, only 82% were even successfully performed, and of those, only 27% gave a sample with tissue adequate for histologic diagnosis. So once again, would a biopsy still be necessary? It wasn't until February of 2009 that the American College of Obstetricians and Gynecologists, ACOG, came out with its committee opinion when transvaginal ultrasound is performed for patients with postmenopausal bleeding and an endometrial thickness less than or equal to 4 is found, endometrial sampling is not required. Now, this was really a sea change of approach. Well, there's been some updated data, and ACOG has taken this into account. They've included still the Carlson, Ferrazzi, and one of the Gull studies. They now have added on this study by Wang of over 4,000 women with bleeding. And they divided this into less than 3, less than or equal to 4, and less than or equal to 5. And in this most recent ACOG committee opinion, it states that for an endometrial echo less than or equal to 3 millimeters, the chance of a cancer was 1 in 383. If you use 4 millimeters, it's 1 in 339. And 5 millimeters, it was 1 in 239. But the document goes on to say that for the average risk woman, the current standard of less than or equal to 4 millimeters as a so-called cutoff, beneath which no further evaluation is necessary, is still acceptable. However, for high-risk women, obese, hypertensive, diabetic, a history of polycystic ovarian syndrome, or patients who rebleed, then further evaluation in spite of that initial thin echo on ultrasound may in fact be warranted. Well, if we're going to do ultrasound endometrial evaluation, what else do I need to be sure you understand? There's some general principles in ultrasound. We want to use the highest frequency transducer that still gives us adequate penetration. Once you do find an echo, use as much magnification as feasible. Make sure you get multiple images in a long axis plane, in the midline and to the right and left of midline, and measurements should be on the long axis view perpendicular at the thickest point. So here's a woman with obviously a thick endometrial echo. This is a somewhat axial, slightly retroverted uterus. The sound comes from the transducer footprint here. This would be the proper way to measure an endometrial echo, perpendicular to the endometrium. This would not be the proper way to measure the endometrial echo. Here's a nice thin endometrial echo. Notice the machine will give you to 1,000th of a centimeter. Really, do we believe that? This is really 1.2 millimeters. It's like an artist took a white line and drew a pencil. You barely can get the calipers far enough apart to measure it. Other limitations of transvaginal ultrasound, realize that not all uteri lend themselves to a meaningful ultrasound examination in order to obtain an endometrial thickness. What gets in our way? Adenomyosis, coexisting fibroids, an axial uterus, marked maternal obesity, previous surgery. So it's essential that you understand that it's okay to do an ultrasound and say, we don't see the endometrium well enough to measure it. Just because you can produce something that's linear and white doesn't mean you should. So here's a video clip of a patient. She obviously has adenomyosis. You can't see an endometrial echo, and there's no point in freezing the frame on something linear and white. You've got to do something else. And in my hands, we would put some fluid into this uterus, sonohysterography, which we'll talk about. Or here's a patient. Yes, you see some of an endometrial echo, but it's lost here. I would not stake my reputation on trying to measure this. It's not reliable. Or this patient has fibroids. You can see the acoustic shadowing of a typical myoma here. You can't evaluate her, there's a fibroid back here too. You can't evaluate her endometrial echo. Or here you see some of the echo, but here's an obvious myoma distorting this. If you really want to know what's going on in this endometrial cavity, you would have to put some fluid in. Or this is a typical C-section uterus. You can walk in the room and see it. The cervix comes along anteriorly and the fundus takes this 90-degree turn. And because this is axial in reference to the beam of sound, it is very difficult. You do not see the endometrial echo nearly well enough. So what can we conclude? Not all postmenopausal women will have an endometrial thickness or echo that is adequately measurable. And the most common reasons, fibroids, axial uterus, adenomyosis. Some examples of good endometrial echoes, well, you like to see it taking off from the internal os and going up towards the fundus. You can actually see the endocervical canal here and this thin, distinct endometrial echo. This I would find reliable. Or here's another one. This woman's 6 years postmenopausal, nice, thin, distinct interface between two sides of inactive endometrium. Here, this is a thickened endometrium, but it's easily measurable, and it measures 8 millimeters, 8.1 millimeters. And so you need to further evaluate what this means. It's important to realize that these endometrial abnormalities are not always global. I can't stress this enough. You realize anytime you show me an ultrasound picture, this is a single frozen snapshot on 2 dimensions, and a single normal, seemingly normal endometrial echo doesn't rule out pathology. You've got to observe the entire structure. And I say here 3-dimensional anatomy reconstructed. You don't need to do 3D ultrasound. If you have it, that's great. But you want to make sure that you survey the entire cavity. So granted, this is not a postmenopausal patient. This is a nice trilaminar estrogen effect. But notice this is to the left of center. This looks like a normal endometrium. Well, we move to the right of center. She's got an obvious polyp. Okay, so this is now a coronal view in the lower uterine segment, looks perfectly normal. This is the polyp near the fundus. And I hope you all appreciate, if we took that long axis view, don't want that. If we took this long axis view here, we would see the polyp. If we take a long axis view out here, it looks totally normal. Or here's an example where we've done a saline infusion. We put some fluid into the uterine cavity, and we're measuring the endometrium at 1.0 and 1.4 millimeters. But you see on this clip, and you're going to see posteriorly here, it's a polyp. And when we turn into a coronal plane, we'll catch a glimpse of the polyp here way off to the left side. I'll show that again. Polyp is on the posterior wall, and it was over here on the left side of the cavity when we turn 90 degrees. I say here the standard of care has changed, but how many clinicians are aware of it? So the American College of OBGYN finally, in my opinion, in July of 2012, came out and said 1/3 of outpatient visits to the gynecologist are for abnormal bleeding, and it accounts for more than 70% of gynecologic consults in the perimenopausal and postmenopausal years. They said that in women aged 40 to menopause, abnormal bleeding may be due to anovulatory bleeding, which represents normal physiology in response to declining ovarian function. In menopause, it may also be due to endometrial cancer, hyperplasias, atrophy, or leiomyomas. So why do I include this perimenopausal information? Well, I say to you that postmenopausal bleeding is not always so easily defined. We know that menopause is the final menstrual period, so it is obviously a retrospective diagnosis. No woman knows that the bleed she just got is the last one she's ever going to get. A classic definition also has been no bleeding for 12 months due to a depletion of ovarian follicles. Now, if you do measure follicle stimulating hormone or serum estradiol, this is notoriously unreliable because it is a snapshot of ovarian function at that time, and the erratic function of the ovaries in late perimenopause often make it difficult to label somebody's bleeding as being definitively postmenopausal. But it may not matter because at least postmenopausal bleeding, our third-year medical students know, is endometrial cancer until proven otherwise and mandates evaluation of the endometrium. But if you follow the ACOG practice bulletin, it mandates that an endometrial assessment to exclude cancer is indicated in any woman older than 40 who's suspected of having abnormal uterine bleeding. Why do we care? Well, in the United States, endometrial cancer is the most prevalent of the gynecologic cancers, fortunately not the most lethal. Why? Because it tends to bleed early. Vaginal bleeding will be the presenting sign in almost all of these cases. Most women with postmenopausal bleeding actually bleed secondary to atrophic changes, either in the vagina or the endometrium. And if you look at all of the studies, the incidence of cancer of the endometrium in women with postmenopausal bleeding ranges from 1 to 14%, although most of them are in that 5% window. Well, what about biopsy? Suction piston biopsy instruments are smaller, cheaper, disposable plastic catheters with an internal piston to generate suction. At least in the States, the Pipel brand has become so popular from marketing that our residents have turned this into a verb. They say, I Pipelled the patient. And I would say that at least in the States, it's a little bit like people say, I'm going to the Xerox machine, even though they own a Canon copier, or hand me some Kleenex tissue, even though it may be a different brand. I say here, though, the reliability and even liability of suction piston biopsy instruments like Pipel has radically changed. So why is there an issue with the Pipel biopsy? Well, I got interested in this. If you put the word Pipel into PubMed, the first article was by Cornier. In fact, it was called the Pipel de Cornier in an article in the Gray Journal in 1984. Of the next 8 papers between 88 and 91, 7 dealt with endometrial dating as part of an infertility workup, something that is no longer done. 1 paper dealt with the amount of tissue obtained with Pipel compared to the previous Vabra aspirator. The next paper in 1991 was widely publicized, and that was by Tom Stovall. What did he do? He took 40 women with known carcinoma. They did a Pipel in the clinic the week before the hysterectomy for the cancer. They found cancer in the Pipel, 39 out of 40 patients. Hence, they said the accuracy was 97.5%. And this was widely publicized in many advertisements in many of the journals. Rodriguez did prehysterectomy sampling. Pipel averaged a sample of 4% of the endometrial cavity when they cut it open. It agreed with the post-hysterectomy diagnosis in only 84% of cases. But Guido really helped us a lot. So what did Guido do? Guido took 65 patients. Remember, Stovall took 40 with known carcinoma of the endometrium. He went to the OR and did a Pipel under anesthesia prior to their hysterectomy. They missed 11 out of 65 cancers. That's like 16%. But then he cut open the uteri. 3 that they missed were less than 5% of the surface area. 4 were less than 25%, and 4 were less than 50%. And of 11 tumors and polyps, they missed 5. So Guido concluded in 1995, Pipel is excellent for detecting global processes in the endometrium. There were other studies. These were done on women with known carcinoma who had a blind endometrial sample. I told you about Guido, and they missed almost 17%. Stovall only missed 2.5%. Ferry with Pipel missed 32%, and Larson using a Z sampler missed 17%. So in my opinion, it is no longer appropriate to do a blind office biopsy procedure unless you first verify that whatever the endometrial process is indeed global and not focal. Well, I wrote that slide 25 years ago. Back to the ACOG practice bulletin, it tells us that the primary imaging test of the uterus for the evaluation of abnormal bleeding is transvaginal ultrasound. It tells us that if transvaginal ultrasound images are not adequate or further evaluation of the cavity is necessary, then sonohysterography, also called saline infusion sonohysterography, or hysteroscopy, preferably in an office setting, is recommended. So what about saline infusion, which we call SIS? Remember, fluid enhances sound transmission. My first rule of ultrasound, fluid is your friend. Think of the baby with polyhydramnios, how well you see. The baby with oligohydramnios, how poorly you see. This is not a filled urinary bladder. This is an old static arm scan. This woman has massive pelvic ascites. Look at the way the uterus is floating. Here's the attachment to the pelvic sidewall, or not my prettiest fimbriated end of the tube, but I like this because you can see the hydatid of Morgagni. Why? She's ruptured a functional cyst. The fluid backdrop enables us to see. This dominant follicle makes it very easy to find this premenopausal ovary, but this ovary in menopause without any follicles, not so easy to see. So if we define a sonohysterogram as putting fluid into the uterus to give us even further detail of the endometrium, they're among the easiest ultrasound scans you'll ever perform. And the technical aspects of finding the cervix and putting in a catheter are pretty simple for gynecologists, slightly more daunting for the radiologists. Sonohysterography should be thought of as a subset of transvaginal ultrasound. when one, the endometrium is not sufficiently thin to rule out pathology, or two, the endometrium is not adequately visualized because of the technical reasons we talked about, fibroids, adenomyosis, axial uterus. So back to the ACOG practice balloon. An office endometrial biopsy is the first-line procedure of tissue sampling in the evaluation of patients with AUB. So understand, for instance, our residents at the public hospital Bellevue don't have ultrasound available. So they will do a biopsy because if it comes back cancer or EIN, which we're going to hear about from Dr. Black, then the evaluation is complete. Endometrial biopsy has high overall accuracy in diagnosing endometrial cancer when an adequate specimen is obtained. And look at this. ACOG finally said when the endometrial process is global. ACOG now says if the cancer occupies less than 50% of the surface area of the cavity, the cancer can be missed by a blind endometrial sample. Positive test result is more accurate for ruling in disease than a negative test result is for ruling it out. Well, that's always true. These tests are only an endpoint when they reveal cancer or atypical complex hyperplasia, EIN. I want to repeat that. This test, the biopsy, are only an endpoint when they reveal cancer, atypical complex hyperplasia. So now that the standard of care corroborates that a negative blind biopsy is not a stopping point, clinicians can still begin with a biopsy, but unless it's malignant or complex atypical hyperplasia, the endometrial evaluation is not complete. So in summary, the main use of endometrial thickness measured on transvaginal ultrasound is the high negative predictive value of a thin, distinct echo. And if your country uses the word stripe, please eliminate it. Stripes are for ties. This is an endometrial echo. In most women with postmenopausal bleeding, an endometrial echo less than or equal to 4 millimeters has a very low risk of malignancy and does not require endometrial sampling. If transvaginal ultrasound is not adequate to rule out pathology, then saline infusion sonohysterography or office hysteroscopy will distinguish global from focal processes and allow appropriate triage. Yes, if it's global, do a blind biopsy. If it's focal, you need to do this under direct vision. New understanding about the high reliability of transvaginal ultrasound with sonohysterography or office hysteroscopy were necessary, and new understanding of the limitations of blind endometrial sampling will result in increasing importance and utilization of ultrasound and sonohysterography in this common clinical entity of postmenopausal bleeding in the years to come. And I want to thank you for your attention and draw your attention to the next World Congress for the International Menopause Society will be held in Lisbon, Portugal, October 26th through 29th in 2022. And by then, God willing, this pandemic will be over and we can all get together in Lisbon and celebrate. Thank you very much.
Thank you so much for such a detailed presentation. It now gives me great pleasure to introduce Dr. Denise Black. She's a Canadian-trained obstetrician and gynecologist with over 30 years of clinical experience. She's an assistant professor in the Department of OB-GYN and Reproductive Sciences, has served as director of postgraduate medical education, and an examiner for the Royal College of Physicians and Surgeons of Canada. But it was an event at IMS in June of 2011 that was an inspirational event for Denise. And since then, she's become quite passionate and well-known throughout the world as a menopause practitioner, published in the field, spoken at international meetings, and is speaking today at this international meeting with our global audience that's well into the several hundreds. Thank you for joining us, and please take the floor, Denise.
Thank you very much, Marla. And thank you, Steve, for setting the stage so well for what I'm going to talk about next. So I'm a clinician. I like to approach problems with problem, solution. And what I hope to do today is to take what is sometimes a bit complicated and make it into something that's a little more workable for us. So I will be talking about management options for unscheduled menopausal bleeding. These are my disclosures. And my agenda for today, I'd first like to address the question of how do we manage unscheduled postmenopausal bleeding with a histopathological diagnosis. because different diagnoses may require different management. And it's going to be important to review what this terminology means, what the data is behind it, and this will allow us to make the correct decision about management. The second thing that I would like to address is management of postmenopausal bleeding when the diagnosis is endometrial polyps. Because there isn't a whole lot of crystal clear direction of what to do with polyps, but I'm hopeful that by the end, we will at least have a better idea of where to start with polyps. And finally, I'd like to tackle the issue of what to do about unscheduled postmenopausal bleeding while on hormone therapy. So endometrial hyperplasia. Back in the good old days when I was training, we were taught that there were 4 different types of endometrial abnormalities: simple hyperplasia, complex hyperplasia, hyperplasia with atypia, and then finally endometrial carcinoma. Well, in 2014, the WHO modified this classification and simplified it. There are now only 2 categories: hyperplasia without atypia or hyperplasia with atypia, also known as endometrial intraepithelial neoplasia, or EIN. And the reason for this is that it was discovered that these are 2 very distinct clinical entities. So hyperplasia without atypia rarely progresses to endometrial cancer. There was a time when we were taught that this was a continuum and that progression along the continuum happened. This is no longer the case. Hyperplasia without atypia rarely progresses to endometrial cancer, 1 to 3% perhaps in 5 years, and maybe as little as 5% over 20 years. And the reason for this is that it does not share the same genetic alterations as you see in hyperplasia with atypia. So hyperplasia without atypia tends to be genetically stable and tends not to progress. And because of this, hyperplasia without atypia may be managed conservatively. And in some instances, that conservative management may include doing nothing. Although I might admit I do have a small amount of discomfort with that, but doing nothing may be an option. In hyperplasia without atypia, lifestyle modification is important to address. And one of the most important things is the association between being overweight and obese and the risk of endometrial cancer. And what we know is that if your BMI is over 30, the odds ratio of developing endometrial cancer is 4 compared to those people that are of a normal BMI. So lifestyle modification, especially with weight reduction, is one of the hallmarks for management of any sort of endometrial abnormality. The levonorgestrel IUS, 52 milligrams, and when I speak about the levonorgestrel IUS in this context, it's always going to be the 52 milligrams that I'm referring to. Use of this device is recommended by guidelines as the first-line option, as compared with oral progestogens, as it has a higher disease regression rate, but it also has a more favorable bleeding profile and fewer adverse events. So this receives a grade A recommendation. I chose a couple of guidelines to discuss when I'm talking about this. Most of the guidelines are in concordance, but this comes from the Green Top guideline, which was a joint guideline from the Royal College of Obstetricians and Gynecologists in the UK and the British Society of Gynecologic Endoscopy. So the levonorgestrel IUS was the first line option. If oral progestogens are used, the recommendation is that they should be used continuously. And in this particular guideline, the recommendation was medroxyprogesterone acetate, 10 to 20 milligrams daily, or northistrone, 10 to 15 milligrams per day. Cyclical progestogens should not be used compared with continuous oral progestogens, as they are less effective. And continued endometrial surveillance is recommended. So it's not enough to make the diagnosis and institute the treatment. You must continue surveillance. Now, endometrial hyperplasia without atypia can also be treated with injectable medroxyprogesterone acetate, 100 milligrams IM Q3 months. And in studies, this showed a 92% regression rate. So although it's not present in the British guidelines, in the Canadian guidelines, this is one of the options that is considered acceptable. And surgical management, and in the postmenopausal woman, let's face that this is going to be hysterectomy with BSO. It is indicated if there is progression on your follow-up testing, if there is lack of regression after 12 months, if there is relapse after treatment discontinuation, and finally, if there was non-compliance with medical treatment. So those are the indication for surgical management of hyperplasia without atypia. Now, hyperplasia with atypia is a completely different clinical entity. This is an entity that, because of genetic and biomolecular changes, is at risk of undergoing oncogenic change. Now, what exactly is that risk of oncogenic change? So endometrial hyperplasia with atypia is considered to be a precursor lesion to type 1 endometrial carcinoma, as the genetic profile of alterations is similar between these two processes. So one is considered a precursor to the actual carcinoma. Now, how often does hyperplasia with atypia progress to carcinoma? Well, in one Danish database review, up to 60% of patients that had a tissue diagnosis of endometrial intraepithelial neoplasia, or hyperplasia with atypia, had already developed an invasive endometrial cancer at the time of their hysterectomy. Now, 60% is kind of the upper end of what we see in the literature. Most of the literature is sort of in the 30 to 35% of people with a tissue diagnosis of EIN who actually have an endometrial cancer present. But that's really just semantics. It doesn't matter if it's 30%, it doesn't matter if it's 60%, the risk is high. Therefore, the recommendation is that in postmenopausal patients, surgical treatment with total hysterectomy and BSO is recommended. A minimally invasive approach should be considered first, just because the postoperative morbidity tends to be lower, and laparotomy should be limited to cases where this is not feasible. Okay. Medical management may be considered in special circumstances, and these special circumstances might be the premenopausal woman who wishes to preserve fertility, or in the postmenopausal woman, it may be somebody who is considered medically unfit for surgery. Now, just a special moment to talk about this. In the state of this global pandemic, where surgical access may be limited, we have been medically managing some of the people that have been diagnosed with EIN or hyperplasia with atypia. Again, this is suboptimal, but in the current climate where global resources are challenged, this may be one of the times where medical management is entertained. And the medical management that may be entertained is similar to what I discussed in the previous slide. So hyperplasia without atypia is unlikely to progress. Treatment with continuous progestogens may be undertaken as an option. Treatment, according to the guidelines, should be for a minimum of 6 months with monitoring. If there is progression, lack of regression, non-compliance, or regression after therapy, surgery may be considered. But in hyperplasia with atypia, or EIN, considering that this is a precursor to endometrial cancer, we have to recognize that many women will have already developed an endometrial cancer. In that instance, minimally invasive hysterectomy and BSO is recommended, although in special circumstances, like I just discussed, medical management may be considered, and the levonorgestrel IUS may be a management, high-dose oral progestogens may be a management option as well. Endometrial polyps. So endometrial polyps are common. In postmenopausal women, maybe up to 1 in 3 women will have a polyp. And it doesn't seem to matter if you're symptomatic or asymptomatic in terms of the prevalence. If you're looking at uteruses of postmenopausal women, you will find polyps in probably 1/3 of them. Now, a polyp is defined as a local tumor in the uterine cavity, which represents focal hyperplasia of the basal level of the endometrium. It's interesting that in these polyps, there's an increase in the estrogen receptors, but a decrease or even total disappearance of the progesterone receptors. So treatment of polyps that are in place with hormones, especially progestogens, really doesn't have an effect because there isn't a progesterone receptor present anymore in most polyps. So what about polyps? How do you decide when they need to be removed? One of the best reviews on this is by Ferrazzi, and this is a review in Italy that took place in 2005 and 2006, published in 2009. And what this looked at was over 1,900 women, almost 2,000 postmenopausal women that had a diagnosis of an endometrial polyp. And this might have been done just with ordinary ultrasound. Some of them actually had sonohysterography done for the diagnostic or for the diagnosis. All of these women had hysteroscopic removal under direct vision. And the results were that if the women had had bleeding and a polyp was diagnosed, the incidence of hyperplasia with atypia was about 2.2%, and the incidence of cancer was about 1%. So if a woman had a polyp and it bled, 3 to 4% was the chance that there was a histological abnormality that required further intervention. In the women who didn't bleed, the incidence of hyperplasia with atypia was low, about 1.2%, and the incidence of cancer was only 1 in 1,000. And that 1 happened to be a polyp that was 4 centimeters in size, so a very large polyp. So based on evidence like this, the American Association of Gynecological Laparoscopists, in their 2012 practice guideline, recommended that symptomatic polyps be removed. Okay? Hysteroscopic resection and removal of the entire polyp, including the root of the stalk, under direct visualization. So no mention is made here about evaluation of the surrounding endometrium with tissue sampling. They said the polyp should be removed. For women without bleeding, the polyp does not need to be removed. And the rationale for that is that for women with bleeding, the incidence of this being a significant finding was greater than the incidence of a complication from the hysteroscopic removal. So that's where the line was drawn. So that makes it easy. What do you do about a polyp? If it bleeds, you take it out. If it doesn't bleed, you don't take it out. But what do we do with the results you get after you take it out? So there really, surprisingly, is a lack of consensus on the management of polyps that are atypical. If the polyps have cancer in them, the management is fairly clear. But if they're an atypical polyp, what do you do? I've reviewed the literature on this just for my own knowledge, so I know what to do. And it was actually surprising how much variation there is. So one retrospective review, which was a conglomeration of 8 retrospective smaller series, showed that the incidence of endometrial cancer in patients with an atypical polyp, so they had an atypical polyp, they went to hysterectomy, the incidence of endometrial cancer was 5.6%. Now, there was 127 patients in total in this conglomeration, and smaller studies had 0% cancer. Larger studies tended to have a higher rate of cancer, but overall, the number they came up with was 5.6%. And when you look at that 5.6% of a concomitant endometrial cancer, you may be more tempted to say, well, maybe I will select which patients proceed to hysterectomy. But a more recent review, and this one is from 2017, so it contained 1,766 polypectomies. And in this series, they were all postmenopausal women. All of them had a hysteroscopic polypectomies, and all of them at the time of the polypectomy, they looked at the surrounding endometrium and said, oh, this looks normal, this doesn't look normal. So in this 1,766 polypectomies, The risk of malignancy or atypia in a polyp was 2.4%, so very much in line with the Ferazzi data. Of those who had atypia or malignancy diagnosed in their polyp, and that was 43, 34 went on to have hysterectomies. In the hysterectomy specimens, 90% had evidence of residual disease or background disease in the endometrium, and the background disease was either hyperplasia with atypia or endometrial cancer. Now, the concerning part of this is most of those, the background endometrium appeared visually normal at the time of hysteroscopy. So when you're removing a polyp, it's not enough just to look and say, this looks normal. Do you then need to do tissue sampling of the background endometrium? Well, in examining some position statements of various societies, the Canadian position statement, because I'm Canadian, says endometrial hyperplasia found in endometrial polyps should be treated according to its histological classification. So if your endometrial polyps is hyperplasia with atypia, you should proceed then with a hysterectomy. If it says cancer, you should proceed to a hysterectomy. Whereas the British guidelines say at the time of polyp removal, sample the background endometrium, and management should be according to the histological classification of what your endometrial sampling says. So those on the surface appear to be different statements. However, if there's going to be 90% concurrence between what the histology is on your polyp and what the background shows, perhaps these are saying exactly the same thing. So what I took as a summary of this is that polyps in postmenopausal women who bleed have an increased risk of hyperplasia and malignancy. Polyps that bleed in postmenopausal women should be removed, ideally under direct visualization with removal of the entire polyp and stalk. If you wish, you can sample the endometrium at the time of the removal. Sometimes that might give you the confidence to say the polyp has been completely removed, and even if the histology is abnormal, I am confident that there is no residual background disease. The management should be according to either the histological classification of the endometrial hyperplasia in the background endometrium or the histological classification of the polyp. Those are going to be concordant most of the time. And just to note that both of those recommendations have low level of evidence, but are the best that we can come up with given what we have. So finally, what do we do about uterine bleeding in women who are on postmenopausal hormone therapies? Well, uterine bleeding is one of the major contributors to the discontinuation of hormone therapy, accounting for up to 1/3 of the discontinuations. And although the exact mechanism of why women bleed on hormone therapy is unclear, some progestogens may induce microvascular changes in the endometrium, and this might be what's responsible for the bleeding. More favorable bleeding patterns may be seen with lower doses of hormones. But really, there are no guidelines for management of uterine bleeding on menopause hormone therapy, other than to advise appropriate investigations. And I would just like to caution that everything that bleeds out of a woman's vagina is not uterine in origin. Please remember that doing a physical examination to exclude non-uterine causes of bleeding, such as cervical bleeding, vaginal tumors, vulvar tumors, etc., is important. It's not good enough just to do an ultrasound. Physical examination to rule out these other extrauterine causes is important. So review of the literature on this topic, management of uterine bleeding on hormone therapy, really revealed no consensus, very little high quality evidence for any particular intervention or change, and very little to go on. And I would just like to recognize that anybody who has been practicing menopause for a period of time has come up with their own particular concoction of how to manage postmenopausal bleeding in women on hormone therapy after significant pathology has been ruled out. We're not going to talk about that today. I'm going to try to keep this evidence-based. So the first thing that I'd like to touch on is take a look at what your endometrial protective agent is. And I would like to talk a little bit about micronized progesterone because this is widely used in many jurisdictions as an endometrial protective agent. And data from the E3N cohort, which was a French study, over 80,000 women, over 8 years in duration, showed an increased risk of endometrial cancer among women who were using estrogen and micronized progesterone. And in fact, ever use of micronized progesterone increased the risk of endometrial cancer to levels seen with unopposed estrogen use. Okay? But one of the issues here is in this study, there was no data on what dose of micronized progesterone was used, how it was used, continuous versus cyclical, and what the compliance rates were. And it's also interesting that the endometrial safety of continuous transdermal estrogens plus oral micronized progesterone has not been properly addressed in studies. The studies which looked at endometrial safety using transdermal estrogens were all transdermal estrogens that were used either 21 or 25 days per month. On a positive note, recently, like just this year, there has been a study which confirmed endometrial safety of continuous oral 17-beta-estradiol 1 milligram with 100 milligrams of micronized progesterone together in a single capsule. So using this regimen, it was fixed dosing and compliance with the micronized progesterone was assured because the two were in the same capsule. So we do have safety with oral 17-beta-estradiol 1 milligram and 100 milligrams of micronized progesterone. A review by Stute in Climacteric 2016 came up with these conclusions. So if you are going to use if you are going to use micronized progesterone, protection at the endometrium is seen with oral micronized progesterone 200 milligrams for 12 to 14 days a month, vaginal micronized progesterone 45 milligrams 10 days per month, or 100 milligrams every other day. The caution is that transdermal progesterone does not provide adequate endometrial protection because absorption is so variable. One of the final statements in this review was that if oral micronized progesterone is to be taken continuously, along with continuous daily estrogen, initial dose should be 200 milligrams per day. This may be lowered to 100 milligrams per day if low or ultra low dose estrogen therapy is chosen. And this was defined as 50 micrograms in a patch or less, and amenorrhea is achieved. So to this body of evidence, we can now add that 100 milligrams per day is sufficient if your dose of estrogen is 17 beta-estradiol 1 milligram orally. All right, another recent article looked at uterine bleeding with hormone therapies in menopausal women. And this looked at continuous combined regimens of estrogen and progestins. This was not head-to-head, and it looked at continuous EPT products available in North America and Europe, but missing were tibolone and T-sex. So what was examined was, going through the literature, rates of cumulative amenorrhea from cycles 1 to cycles 12 and 13, amenorrhea rates at the end of the first year of use, and overall amenorrhea, as well as discontinuation due to bleeding. And the conclusions of this review were this: the bleeding generally improves over time, with the highest rates of bleeding seen in the first 6 months of continuous combined use. In this review, oral hormone therapy provided better bleeding control than transdermal hormone therapy, but the limitation of this was that the products that were used transdermally were fixed dose regimens and they contained progestins. Okay, so there was limited progestin choice. Because remember I told you progesterone does not absorb transdermally? That's true. But synthetic progestins can be used transdermally with appropriate endometrial protection. In some non-head-to-head studies, there was the suggestion that oral 17-beta-estradiol 1 milligram with micronized progesterone 100 milligrams once a day was associated with a better bleeding profile compared to products which contained synthetic progestins, although also performing very well was a combination of ethinyl estradiol and neta. More favorable bleeding profiles were seen with lower dose products, and better bleeding profiles were seen in women further from the time of their last period. So women closer to the time of their final menstrual period had a little more issues with bleeding on these hormone therapies. So what about T-sex? Because we do have those in Canada and the US and several other parts of the world. So the combination of conjugated estrogen 0.45 with bazodoxifene 20 milligrams as the endometrial protective agent had a demonstrated bleeding pattern very similar to placebo in terms of amenorrhea and cumulative amenorrhea throughout the 2 years of the clinical trial. And I'm going to show you that data in just a minute. And for women on other hormone therapies who switched from other hormone therapies to the T-sec because of either breast discomfort or bleeding, over 97% experienced resolution of their symptoms. So just to look at the bleeding data with the T-sec, this was a head-to-head comparison with conjugated estrogen 0.45 and MPA 1.5 milligrams. And this kind of gives the typical pattern of what we see with the continuous combined products: higher rate of bleeding in the first 6 months, getting better over time. But still at the end of the first year, there was about an 8+% people having unscheduled bleeding. Whereas with the T-sec molecule, it was very similar to placebo with high rates of amenorrhea seen by the end of the first year. What about tibolone? Because although you don't have tibolone in the US, we have this in Canada, and it's very popular in many other parts of the world. So in postmenopausal women with a mean age of 54 years, those taking tibolone had an unscheduled bleeding rate of about 10% at week 52, which is very similar to what was seen with the bleeding profile with the 17-beta-estradiol 1 milligram micronized progesterone 100 milligram that we spoke about earlier. So similar, about 10%, probably better bleeding rates than many products with estrogen and progestin. So in summary, in this little part, we have very little scientific evidence-based guidance on the topic of how do you manage postmenopausal bleeding in women on hormone therapy after you've ruled out pathology. So with continuous combined therapy, investigation of unscheduled bleeding, which occurs after 6 months of therapy, is appropriate and supported by all major guidelines. There's very limited evidence without much direct comparison, suggesting that better bleeding profiles may be seen with T-sec, tibolone, micronized progesterone 100 milligram and 17-beta-estradiol 1 milligram, or the ethinyl estradiol neta product. One paper suggests that a switch to T-sec might improve bleeding symptoms in most women. So thank you for your attention. I'd like to pass it over to Marla now and have some questions.
Thank you, both of you, for such excellent presentations. We are going to try and keep to time, but we do have a number of questions that have come up, and I'm going to go through them. Everybody has sent their greetings, so we send our greetings right back to Mexico and all over the world. Thank you for the greetings. Yeah. First question: would every case of postmenopausal bleeding after TVS showing a transvaginal ultrasound showing thin endometrium require a diagnostic hysteroscopy for proper diagnosis and subsequent treatment?
No, I mean, at that time, I think that was the gist of my entire talk, that if you've got a thin, distinct endometrial echo, you don't need to do more. I think what perhaps the questioner is asking, if that patient rebleeds, in other words, after you've done a thin echo, let's say 2 months later, this patient presents with another episode of bleeding, then I think you have to be more aggressive. Elizabeth Epstein has presented data that in patients who rebleed, they have 10 times the risk of having endometrial cancer. So, ultrasound is really good, but it's just a little bit of common sense. If they continue to bleed, I would be more aggressive. And I think hysteroscopy, probably, office-based, is the way to go.
I have a question from Bangladesh, from Dr. Mariam, who's asking us, is there a role of MRI at all for investigations?
No, really. I mean, all the data, all the normative data about endometrial thickness has been developed with transvaginal ultrasound. I would even be careful about not translating this to transabdominal ultrasound. Really, none of the work has been done that way, and there's really no need to subject these patients to MRI. I think if you use a good transvaginal ultrasound and saline infusion, is very simple to do in cases where you need it. You can get to global versus focal or no pathology relatively easily without MRI.
This is a question for both of you from Australia. Thanking you both for excellent presentations. Could you clarify the role of transvaginal ultrasound in a patient who's had a previous endometrial ablation who now presents with postmenopausal bleeding? Asking both of you to share your own practice-based experience in relationship to this.
Well, I get asked this question all the time, and it is really difficult. A lot of patients get sent to me thinking that I am like so special that maybe I can make it work. The honeycomb kind of scarring that you often see with a global ablation device makes any kind of assessment extremely difficult. It's difficult to get a good ultrasound. It's difficult to, even if people still believe in biopsy, to do that. It's difficult to get fluid to expand any cavity with the adhesions. Your best bet is patient selection. In a review of patients who developed endometrial cancer after ablation, we found that 30% had had a diagnosis of simple hyperplasia, regardless of whether the genetic mutations were present, and that something like 60 or 70% were obese, either by description or BMI in the chart. So I think that you need to be careful. Global ablation is meant for heavy menstrual bleeding, and somehow it's been extended to intermenstrual bleeding. Cancers don't bleed heavily every 28 days. So patients who have regular cycles that are heavy are candidates for ablation, but don't extend this necessarily to metrorrhagia, as we called it, because that may be an undiagnosed pathology.
So
And if
Denise,
I could add
go
a
ahead.
comment to that I think that most guidelines now recommend that endometrial ablation should be reserved for people that fail medical management for their abnormal bleeding. And the way to prevent that situation is to consider medical management first. And I think there's really good evidence that use of the levonorgestrel IUS provides management of heavy menstrual bleeding that's as good as an ablation. So try to avoid the ablation in the first place, because once you get to the postmenopausal bleeding in a uterus that's been ablated, it's a nightmare.
Yeah, this next question takes off right on that. This is for you, Denise, can you share your experience of putting in an IUS post-hysteroscopy after polyp removal while you're waiting for the biopsy report? And then if it turns out that the polyp is benign, would you take out the Mirena?
6 of one, half dozen of the other, and it would depend on the clinical situation. And, when I was talking about polyps, I excluded people that were on tamoxifen, but there may be situations like if someone is on tamoxifen where you leave the Mirena in, or if they have additional risk factors for endometrial cancer, that leaving the Mirena in the levonorgestrel IUS in would be a completely appropriate thing to do.
Okay. Next question. Can you give us guidance on estrogen therapy, the limits in patients on sequential hormone replacement therapy or continuous combined hormone replacement therapy with bleeding problems? What would you prefer?
Are you
So sorry.
asking about the ultrasound findings in these situations? Not sure what the question.
You can expand the question any way you want, Steve. You can give us a scenario.
I guess understand that if you give somebody sequential hormone therapy, they're going to have a big, thick endometrium by the time they're getting ready to bleed. You're giving them estrogen, which will proliferate the functionalis. Then you give a progestational agent to convert it to secretory, and then they shed it. So if you're going to use ultrasound in a sequential patient, you really need to do this just as the bleeding cycle ends, when the endometrium is going to be as thin as you expect it to be all month long. If a patient is on continuous combined, if you look at that histologically, it is a very low level of decidualized endometrium, a progestational effect, which you don't see in nature. It doesn't exist, and without any proliferation, very thin layer. The question often comes up, well, how thin on ultrasound should it be if a woman is on continuous combined? And there really are no normative data. The same thing holds if somebody on continuous combined bleeds. I personally think they often will be more than 4 millimeters, but I think if you're going to rule out pathology, you really are relegated to say you need to see it under 4. Otherwise, you're going to go to some other level of investigation. Although I think if they've been getting a progestational agent, their chances of having a malignancy are going to be significantly less than the woman who spontaneously bleeds, who hasn't had any hormones in 5-10 years.
Denise, this is for you. If you've chosen to use a levonorgestrel IUS for the management of hyperplasia, how would you then continue to surveil them afterwards?
So it is completely possible and appropriate to do an endometrial biopsy with the device still in place. Absolutely, you can do it without any issues. So you can get your histological diagnosis. You may or may not choose as well. If Steve, you might want to comment about, do you do ultrasound surveillance? But I think the heart of that question is, can you do a biopsy with a IUS in place? And the answer is absolutely, without question.
I mean, your ultrasound is going to be limited because of the shadowing from the device. So ultrasound and using the parameters that I talked to, plus I would not do a sonohysterogram on somebody with an IUD in place. I don't think it'd be very valuable. It does underscore, you say it's one of the first choices for treatment of hyperplasia. I personally have used a progestogen, given in the doses that you mentioned for the very reasons that people are asking about. I find it very difficult to properly manage. And I've already expressed my concern. If you tell me that the patient with simple hyperplasia had a global process to start with, which often they do, well, then I'd be comfortable with a follow-up biopsy. But if the process is focal, the same problems that I have seen with biopsy may still exist.
Okay, what is the safety data for using micronized progesterone in hormone therapy, preventing endometrial cancer beyond 5 years?
So again, most of the safety data with micronized progesterone for opposition of estrogen that we're giving, most of the data actually looks at sequential use rather than continuous use. So the data beyond 5 years is limited, but that's the limitations of our data.
Okay. Can you differentiate with certainty an endometrial polyp from a thickened endometrium in a postmenopausal woman by ultrasound?
Well, not by unenhanced ultrasound. In other words, you have a thick measurement. You don't know if that's just a focal area thickening or truly a polyp with a stalk and a feeder vessel. That's why I think you need to do saline infusion sonohysterography. And even that is not 100%. In that Ferrazzi paper that was so nicely presented by Denise, they had one case of cancer in a polyp that didn't bleed. They had 3 others that they diagnosed as polyps that simply turned out to be polypoid focal thickening. So some people believe that you can find a central feeder vessel to make a definitive diagnosis of a polyp, but I would say there's a focal endoluminal mass is the way I often describe it, and it needs to be dealt with hysteroscopically.
Okay. If you have a patient with abnormal bleeding who's on hormone therapy and the endometrium is thin, would you perform a hysteroscopy? Would you perform a biopsy? Would you just change the therapy?
It's a great question. I guess that's where you sometimes have to individualize. I mean, if I truly am comfortable that I've seen the entire endometrial cavity and there really is no anatomic source of that bleeding, I've got a 2.4 millimeter endometrium, and I see that beautiful white line I showed you, I would change for therapy. If there's any doubt about what I'm seeing, then I would go to either saline infusion or an office hysteroscopy. It depends on your index of suspicion, and you're allowed to take into account that you have other risk factors.
Okay, are there racial or ethnic differences in the mean endometrial thickness in postmenopausal women? It's an interesting question.
Yes, very interesting question. I'm not aware of any that have been truly looked at. Understand, you ask about mean endometrial thickness. That's not what we're looking at. What we've done here is we've attempted to use ultrasound to identify people who have no tissue in whom we can leave alone. We don't know what the mean thickness for various states are, but we're using this in patients who have bled to decide who can not have to undergo any further evaluation.
Are you concerned about dissemination of cancer cells when you do an SIS?
Great question. It comes up a lot. First of all, when we do hysteroscopy, we don't seem to be concerned about disseminating cancer cells. Number 2, no longer are cell washings done at the time of the hysterectomy for cancer that can affect its staging. And number three, there actually are two studies, one by De Sole and the other author I forget, but they both came out of Europe, where people actually went to the OR and did an SIS on cancer cases before the hysterectomy, and then did cell washings. And in one instance, the instance of positive washings was only 6%, and the other, it was 7%. So no, this should not inhibit you from doing saline infusion or even, saline-based hysteroscopy in the office.
Denise, this is for you. We often perceive that micronized progesterone is a good option in postmenopausal women because of the breast risk. Is it a safe long-term option?
So that's the $1 million question, and can you have it all? Micronized progesterone is widely perceived to be more breast friendly, but I think that we have to look at the fact that perhaps at the level of the endometrium, it does not provide quite the robust protection that we see with synthetic progestins or other molecules. Now, having said that, I think that it's appropriate to take into account the dose of estrogen, whether using the dose of micronized progesterone, sequential, continuous. There's so many factors that go into deciding, whether or not this is an appropriate thought for long-term endometrial protection. But wouldn't it be nice to be able to have it all?
So we've got lots of questions about IUSs, so I'm going to try and group them. If you have a patient with non-atypical endometrial hyperplasia, after you've done your aspiration, is that patient a good candidate for estradiol 1 milligram oral and a levonorgestrel IUS for the management of the postmenopausal bleeding? I think you talked about that.
Yeah, so anyway, the IUS will provide some endometrial protection. It will provide some regression if there is any tissue abnormality. The whole issue about whether you want to add estrogen to somebody that's already got a diagnosis of hyperplasia is one where there is some controversy. So I don't know that there's an easy answer to that one. Steve, what do you think?
There's really no data to support that. I mean, it may be convenient and it's sort of, making it up as you go along, but I'd be reluctant. I'm not aware of any studies that have looked at doing that, and I would be reluctant to do that.
So we're just running after 7. There's 2 more questions that I'm going to ask you before we close this. Again, talking about levonorgestrel IUS, is there a rule for women who have diagnosed FIGO1 adenocarcinoma?
So yes, there is. And there's actually some data that shows that use of the levonorgestrel IUS 52 milligrams, not the littler ones, the 52 milligrams, that there is some spontaneous regression or at least slowing of progression. And in the postmenopausal person who might be a poor surgical candidate, in the times that we're in right now where access to operative intervention might be delayed, then this is absolutely an appropriate and evidence-based management option.
Okay, and here's another great question about Mirenas. The use of using a Mirena for a woman who is on tamoxifen with heavy menstrual bleeding, who's had a normal hysteroscopy and biopsy, would you use a Mirena in that case?
So the thing that we always have to remember is the unknown with levonorgestrel IUS 52 milligrams is what is its impact on breast cancer risk or recurrence? Okay. For women who are on tamoxifen, there is some evidence that use of the IUS can prevent formation of polyps, can prevent tissue abnormalities inside the uterus. What is somewhat unknown is whether it impacts breast cancer recurrence risk. There is some data that says it does not, but it's not considered definitive. So that always has to be the question that you weigh.
Okay.
I would weigh in, understand that tamoxifen is a very different drug if the woman is premenopausal versus postmenopausal. You can see some extremely high estradiol levels in premenopausal women, and actually it's a cousin of clomiphene citrate, so it's very likely to cause women to become ovulatory. You can also see growth in fibroids or endometriosis, and yet interestingly enough, the breast is protected because the tamoxifen locks up the estrogen receptor of the breast, not necessarily anything to do with progesterone receptors. So I'd be a little reluctant. I'd also be concerned that the questioner didn't ask or didn't say how old is that patient, is she premenopausal or postmenopausal, and I'd be a little concerned about whether you possibly missed some endometrial pathology if she's bleeding that heavily.
And if a patient is on an estradiol patch of a 50 microgram, what would you choose, 100 or 200 milligrams of your progesterone?
Okay, so if we're talking about micronized progesterone, I
Yes.
think that some of the things that I would take into consideration, what is the body habitus of the patient, the BMI, because that might prompt me to use a higher dose of micronized progesterone. If you believe the data from Stute, it says start with 200 milligrams if you're going to use it continuously. And if the patient is amenorrheic, if the dose is low or ultra low, and if she doesn't have an elevated BMI, then I could back down to 100. And again, the data from the 1 milligram 17 beta estradiol, 100 milligrams micronized progesterone is very reassuring, because the cross potency or equivalency 50 microgram patch is about the same as a 1 milligram of oral. So that gives me some confidence to use the 100 milligrams OD in the carefully selected patient with those parameters.
Last question is for you, Steve, and I'm not sure why they're doing an annual transvaginal ultrasound in a postmenopausal patient without bleeding, but they are. This is a postmenopausal woman. She has no bleeding. She had an endometrial lining thickness of 6 to 7 millimeters, and it's a millimeter more than the last ultrasound done 10 years ago. Should we do something about that?
Maybe that's another webinar, but I would say the following, that as many as 13% of postmenopausal women have a thick endometrial echo and have not bled. That's 1 out of 8 women. All we ever said was, if they're bleeding and it's thin, that's good. Why people have ever taken that to believe that if it's thick and they're not bleeding, that's bad. There's abundant evidence that when you have endometrial thickening without bleeding, these patients should be left alone, unless you are allowed to individualize. I mean, if they've had a history of polycystic ovary syndrome, they weigh 100 kilos, or 220 pounds, that's a whole different story. I'm concerned about, have we created a monster with people being comfortable with a thin echo and therefore being concerned about thick and not understanding what the background noise would be. In reference to your question about going from 6 to 7 millimeters, I mean, that's a measuring error. That can be the way the probe is angled, the way the measurement was done, but if you tell me that somebody truly in your hands with a reliable echo was like 3 millimeters and a year later it's 10, I would say that that's something interesting that should not be happening unless she's recently menopausal and perhaps had a blast of some ovarian function. But if she's 67 years old and you see that, you may want to investigate that. But once again, that's a case-by-case basis. There is no number above which, and let me finish with this perhaps, there was a paper by a woman named Rebecca Smith-Binman, who's a radiologic epidemiologist at University of California, San Francisco. And in it, she had a theoretical cohort study. There was no one studied where she assumed that 15% of endometrial cancers would not bleed, and therefore said that if the echo measured more than 11.2 millimeters, there was a 6% chance of having cancer. Many, many people have thrown that up for many years, that 11 millimeters is some magical cutoff above which you should sample. And that's just not accurate. I don't know why we have thought that the thicker the measurement, the more dangerous it is. I understand the thinking of that, but the reality is most cancers bleed relatively early. Remember the slide I showed you in those observational studies, we're bleeding at 7, at 5, at 9. Endometriums that get to 25 or 30 and haven't bled tend not to be the cancers. In my experience, they tend to be simple hyperplasia and they tend to be large benign polyps.
And truly the last question for Denise, to give you the final word, Denise.
Yay!
I saved it. Would you consider using microdose progesterone vaginally for better absorption and to avoid the first pass effect of the liver? Do you think that that's a better thing to be doing?
Whether or not it's better, I don't know that there's any data to say it, but it's certainly an acceptable option. So we know that although micronized progesterone does not absorb through the skin, it really absorbs nicely through the vagina. And when you use it vaginally, you bypass the sedation that you get when you take it orally. And some people find the sedation to be beneficial because they sleep better, but for some women, they really don't enjoy it. So micronized progesterone can be used orally and it can be used vaginally. And as we've seen from the previous data, both can be used safely if you're following the dosing recommendations.
Okay, well, with that, I want to thank both of you. We have gone over because there's been so many questions and it's been such a terrific seminar. And there's a number of comments here from Peru and from India and from Australia and all over the world, literally from a global audience, thanking you for such a brilliant presentation and thanking IMS in general for the series of lectures that have been going on. And clearly with the numbers that we're seeing and the concern that we think about COVID fatigue and people not wanting to watch these, we've had several hundred who are on the line with us live tonight, and we know that there'll be many, many more watching the tape session. So I want to thank you both for two excellent presentations. Our next Save the Date, which is a must, I think, is dealing with something we're all interested, the big issue of weight gain at midlife. And that will be December 15th, and you can convert it to your time zone with a new moderator and two other international global speakers. And I'm sure it will be equally excellent as tonight was. So I want to thank our presenters, Dr. Denise Black and Dr. Steve Goldstein, our North American big excellent speakers, and want to thank all our global attendees for making tonight such a wonderful evening. And this will be available to review if you want to see again by tape, because it has been recorded and will be available to you. So with that, I want to say thank you and good night to all.
Thanks, Marla.
Marla.
Thanks.